Hey guys, in this video I am going to cover all the brain tumors with clinical finding, pathology finding and radiological finding. So let's start. First is retinoblastoma. So retinoblastoma, we know it is the most common intraorbital tumor in a child, and the hereditary pattern is 60% sporadic and 40% is only hereditary. In this 40%, 7% is familial and other 30% is non-familial, and the most common inheritance pattern is autosomal dominant, and the gene is, we know it is RB gene, and RB gene is located on 13 chromosome, so 13q14, and other RB associated tumor is osteosarcoma. Now the clinical features. So mostly it is going to be leukocoria in the eye, and second one is esotropia. Now in USG you can see the calcium deposition, and contrast enhanced MRI is the investigation of choice, as we know that all the neurons are going to be best seen in an MRI. So mostly all the CNS tumor investigation of choice is going to be MRI. I mean, if we can see the biopsy, then it is best for any malignancy. So biopsy and MRI. MRI is going to be radiological investigation of choice, and biopsy will confirm the diagnosis. But for the brain tumor, if by radiological by MRI, if we can confirm the diagnosis, we will avoid the biopsy for the brain tumors. So in biopsy, the Flexner Winter-Steiner rosette, that is true rosette, will be seen. Now there is mainly three type of rosette. So let's first talk about the rosette. So true rosette and other two is pseudo rosette. So the true rosette are known as Flexner Winter-Steiner rosette. What do you mean by true rosette? That the surrounding cell with empty lumen, I mean the lumen will be totally empty looking lumen will be there, and the two pseudo rosettes are Homerite rosette and perivascular pseudo rosette. So in Homerite rosette there will be it will be pale neutropil, means central part will be like eosinophilic material will be there, and in perivascular pseudo rosette there will be vessel. So here in retinoblastoma it is true rosette, means Flexner Winter-Steiner rosette, which are true rosette, empty lumen, and also sometimes there can be Homerite rosette, which are pseudo rosette, can be also seen here. So let's see here that it is a Flexner Winter-Steiner rosette, which are totally empty looking lumen like rosette and surrounded by hyperchromatic small nuclei containing cells, and in Homerite rosette we can see the nucleus is completely occluded. Now the drug we give here is CEV. You can remember that, cave. So carboplatin, etoposide and vincristine. Now the second one is medulloblastoma. Medulloblastoma is actually the most common malignant tumor in the children, and what is the location? So medulloblastoma, we know that it will happen in the medulla, so posterior fossa and in the midline, and the metastasis is by CSF trop, and it is known as Zuckergus. And in medulloblastoma there will be Homerite rosette, means pseudo rosette. So rosette with cytoplasmic processes in the lumen with surrounding small round cell, and all the other tumor which is gonna have this Homerite pseudo rosette is neuroblastoma, pineoblastoma and Ewing sarcoma. Now the third one is ependymoma. So ependymoma is actually a type of glial tumor, glioma. So we have learned this retinoblastoma and medulloblastoma. They are neuronal tumor. Now this is glial. So we know that in brain there are actually 4 types of glial cells. I have actually a photo of the classification of neuronal cells. So we know that in CNS there are actually 4 types of this glial cell: astrocyte, ependymal cell, oligodendrocyte and microglia. So now we are going to learn about this glial cell tumors. So first we learn this ependymal cell means ependymoma, and ependymal cell we know that it is a lining of ventricles in the brain, means they are going to produce the CSF and astrocyte. Then we will learn this pilocytic astrocytoma and its classification. Then we will learn the oligodendroblastoma. So oligodendrocytes are the myelinating cell in the central nervous system, while the Schwann cell are the myelinating cell in the PNS, while the astrocytes are important in maintaining blood-brain barrier. Okay, so let's see now the glial cell tumors. So first one is ependymoma. So ependymoma is associated with neurofibromatosis 2. So in neurofibromatosis 2 there is going to be three tumors: ependymoma, schwannoma and meningioma. And in this neurofibromatosis 1 there is going to be pilocytic astrocytoma. So ependymoma is associated with neurofibromatosis 2, and in ependymoma we will see the perivascular pseudorosette, means perivascular nuclear free zone consisting of thin ependymal process radiating towards the central blood vessel. As you can see here, central blood vessel, and surrounding it we have this thin ependymal processes radiating towards this blood vessel. Now this pilocytic astrocytoma, so we have WHO grade classification. So for astrocytoma, pilocytic astrocytoma is grade 1. It is actually benign tumor, and this pilocytic astrocytoma is the most common benign tumor in children. And low grade astrocytoma is most common, I think, tumor in adults, benign tumor in adults. And this glioblastoma, which is grade 4 in astrocytoma, is actually the most common malignant tumor in adult. Then there is oligodendroglioma. The classification is only grade 2 and in grade 3. So let's see now the pilocytic astrocytoma. It is also known as optic glioma. So pilocytic astrocytoma is retroorbital tumor. As it is optic glioma, we know that it is going to be occur around the optic nerve. So retroorbital tumor, and it is associated with neurofibromatosis 1. It is a fusiform shaped tumor. So you can differentiate it from the meningioma surrounding the optic nerve. It will this tumor is going to be fusiform, and this meningioma is going to be tram track line. Now the marker is GFAP. So GFAP is going to be seen in this pilocytic astrocytoma, then glioblastoma and oligodendroglioma. This 3-1. Okay, now the histopatho finding is very typical for all this CNS tumor. So we have to remember about the each one. So pilocytic astrocytoma has biphasic architecture, so loose microcytic component and dense fibrillary area. So pilocytic astrocytoma is this very dense fibrillary area, and this Rosenthal fibers will be seen. So what is Rosenthal fiber? We know that pilocytic astrocytoma is a benign glioma. So all glial cell is going to be GFAP positive. What is GFAP? It is actually intermediate filament. So this filament is going to aggregate and are eosinophilic corkscrew shaped, so they are known as Rosenthal fibers. Now there is also eosinophilic granular bodies known as mulberry like inclusion. So you can remember that this pilocytic astrocytoma has very rose pinky mulberry like inclusion, Rosenthal fibers, and also hair like projections, as you can see here. Now the glioblastoma. So glioblastoma is also GFAP positive, and we have learned it is a WHO grade 4, means it is going to be very aggressive tumor, very poor prognosis, high grade tumor. And what will happen when the tumor has very high grade? It is going to be grow very fast, and so if the tumor is growing very fast, what will happen? Some tumor cells are not going to get the nutrition because they have less time to form the blood vessels, so large area of necrosis will be seen. So as you can see here, this large area of necrosis and the peripherally arranged nuclei will be seen. So this pattern is known as pseudo palisading pattern. So this is pseudo palisading pattern, and if you can see the gross appearance, it is going to be butterfly shaped and crosses midline heterogeneously, enhancing tumor. Now the oligodendroglioma. So oligodendroglioma, we know that it is also GFAP positive, and it is a testy tumor of brain because it has two typical appearance, fried egg and chicken wire. So in fried egg appearance, as we can see here, the nuclei containing finely granular chromatin surrounded by a clear halo of vacuolated cytoplasm, and this chicken wire capillaries will be seen. And also you can remember that the genetic part, it is 1p19q co-deletion. Okay. Now the schwannoma. So schwannoma, we know that it is a vestibular schwannoma most commonly, so CP angle tumor, and the finding will be mostly tinnitus, hearing loss, and the most common nerve involved is inferior vestibular nerve, and they are also associated with neurofibromatosis too. Another name is acoustic neuroma. And ice cream cone appearance will be seen grossly, and in histopathology you can see this Antony A and Antony B area. So Antony A are densely cellular while Antony B are hypocellular, and so Antony A area have this varicose body. So this two line of nuclear palisading will be then, and central nuclei free area. So as you can see here, palisading nuclei centrally, there will be nothing. So this is Antony A and this is Antony B, which is actually hypocellular. As you can see, this is all Antony A, this is Antony B, and this is verrucate bodies. So this schwannoma, this oligodendroglioma, this glioblastoma, then this pilocytic astrocytoma, this ependymoma, all are just glial cell tumors, and it has very typical appearances that we have to remember. And the last one is of meninges. So meningioma, and it has vimentin and EMA positive and associated with neurofibromatosis too. And in gross appearance you can see this dural tail sign, and in histopathology you can see this wall like pattern, which is Samoma bodies. And we have done this benign and malignant most common part, that in children the most common benign tumor is pilocytic astrocytoma, in adults it is astrocytoma. Malignant one is medulloblastoma in children and glioblastoma in adults, but overall most common tumor in CNS is always going to be secondaries from the lung cancers.